I'll start the sip and see. I think we don't call it spine and wine because we've all learned that there's much smarter doctors and radiologists, obviously. So the physicians here at Center for Spine and Orthopedics, I'd like to welcome everybody to tonight's virtual sip and see CME event. I'm Jake Rumley. If anybody doesn't know, I'm the spine surgeon or a spine surgeon at Center for Spine and Orthopedics, and I'm also the medical director here. We're happy to provide this continuing medical education series twice yearly, featuring various spine, orthopedic, and pain management topics, as well as podiatry, which we have here in this clinic for our local community physicians to help support us. I'd also want to thank Health Images, our co-sponsor for our lecture series, as they really help with this. And I can say personally, they've been a wonderful partner to us, really helping get patients in and doing a quality job with their radiology interpretations of our imaging. It's been my go-to for them, even outside of them sponsoring us for this. It's been a very natural transition or use of doing it with them. Tonight, we're going to begin with a wine tasting by Dr. Downs. The wine tasting will then be followed by Dr. Kershen from Health Images, who's going to help lead us to understanding the appropriate imaging order for patients of all ages with knee injuries. Then after that, we'll have Dr. Beck begin our main presentation on swollen knees 7 to 70, traumatic and atraumatic causes. Then at the end of her lecture, we'll have a brief presentation from our certified athletic trainer, Mark. Mark, I've never said your name. Your last name, Zaccone. I hope that's right. Is that a thumbs up? No.
It's Zaccone. I
Okay.
always say I'm not that Italian when people say Zaccone.
All right. Well, I screwed that one up. Help, and he's going to talk about us to help understanding the management of effusions when they come into our clinic. So let's go ahead and get started. It's my pleasure to introduce Kevin Downs. He's a wine som, and he will lead us with tonight's wine tasting. Dr. Downs is a retired OB-GYN physician who specialized in fertility. He's also a former event planner at Wyatt's Wet Goods in Longmont, which I live up in Frederick, so it's a wonderful place to go. Kevin became interested in wine during his years as a physician. I'd like to welcome Dr. Downs to lead this.
Thank you. Well, good evening, everybody. So tonight we're going to go to Greece. Such a nice time of year to go to Greece. Not many people know much about Greek wines. Those that do, probably the only wine they've heard of from there is this whole god-awful wine called Retsina. Retsina is a white wine that dates back hundreds of years, and they would ship this white wine all over Europe. They didn't have corks back then, so what they did is they had these large ceramic amphoras that they would, that they would actually seal the opening with pine resin. That pine resin got into the wine, leached into the wine, so you literally had a wine that tasted sort of like a pine tree. For some reason, that wine has remained, and you can get it to this day, although God knows why you would want to. So that's what most people know about Greece. However, the Greeks make some wonderful wines. There are wonderful wines made throughout the Balkan region and throughout Greece, and they're really underappreciated, and not a lot of people know enough. So tonight I'm going to try to put in a plug for the Greeks. So we're going to do a wine tonight. That's the name of the grape is Agior Agatico. Agior Agatico originated in a little tiny village near Nemea in central Greece. The name of the town was Agios Georgios, which literally means the town of St. George. So, as a marketing ploy, the Greeks decided that we should probably not call it Agior Agatico because nobody would be able to order at a store. So they changed the name to St. George. So here we have St. George. St. George is the grape that is actually grown throughout Greece, and it is by far the most vineyards planted in Greece are to this particular grape. It's a wonderful red wine. It's typically macerated and fermented in stainless steel. It's aged in French Baroque for about 12 months, and then it's aged in bottle about 6 months before release. So it's not aged, you don't get a ton of oak on it. It just has this delightful, pure red and blue fruit for a little bit of spice, wonderful nose, and it's just a great bottle of wine. The grape itself is adapted beautifully to Greece. It loves a warm, dry climate, which Greece certainly has. The only problem with the grape, it's very prone to various diseases in the vineyard, particularly mildew. So it requires incredibly intense vineyard management, but they're rewarded greatly. This is a great bottle of wine. As I say, it's got very wonderful red and blueberry fruit. It's got a hint of spice, maybe even a little bit of cinnamon in there. Finished with a little pepper on the finish. Goes great with almost any food, not only Greek food. And it's not very expensive. So it sort of ticks all the boxes for people that want to enjoy a wonderful red wine. So enjoy and come back and try to look into some more of these wonderful wines from Greece. I think you'll enjoy them all. Have a good evening.
All right. Thank you, Dr. Downs. That's great as normal. I learned so much. I'm not saying I don't learn a lot from the surgeon providers, but that part's so cool because it's so different than what we do on a daily basis. Next, I'd like to introduce Dr. Michael Kershen. He's going to speak today about imaging and knee pain and swelling. Dr. Kershen is the chair of operations for Colorado Imaging Associates, and he completed his radiology residency at Baylor University Medical Center in Dallas, Texas in 2014. And he's also finished a musculoskeletal radiology fellowship at the University of Virginia in 2015. He's been wonderful every time he's been on. It's great to have him back. So thank you, Dr. Kershen.
Yeah, thanks for having me. Let me just share my screen here and we'll get started. Okay, so we're going to be talking general overview of imaging and knee pain and swelling, something that is a very common occurrence in our society, particularly here in Colorado, as people are so active, and particularly during the high tourism seasons. We just got out of ski season, so our volumes are a little bit down, but we'll go over some of the indications for this and what you might consider ordering. So the key points of this are to determine what views in X-ray imaging are optimal, and special considerations for imaging with X-ray, how to order an indication for MR imaging, the indication for CT imaging, and special considerations for using ultrasound in very limited conditions. So I always start off my talks with saying X-ray imaging is the workhorse of any imaging we do. It should basically always be the first study that you order. Not only can it make diagnoses by itself, but often when we're doing these additional imaging, particularly with MRI, there's much pathology that actually we need an X-ray to hone in on that diagnosis, or help us to make a good diagnosis on that. The positives of X-ray are it's physiological, so you can do imaging and weight bearing. It's quick, it's relatively inexpensive, it's easily tolerated by the patients. A few drawbacks are there's a small radiation dose, and of course there's poor soft tissue delineation, so you can't see muscles, tendons, meniscus, ligaments very well. So when you're thinking about ordering an X-ray, the standard order, particularly for just kind of a knee pain, maybe an older person with knee pain, would be a 3 or 4 view of the affected knee. Our typical 3 view would be an AP image of the knee, a lateral, and a tunnel view. And then depending on some other indications, you might consider adding a 4th view, which would be potentially a sunrise view or an AP weight bearing view. And we'll go over what those look like and what the pathology we're looking for on those images are. With the weight bearing, we have a more natural position of the patient. We're better able to look at the alignment of the knee, and it's the best imaging typically for osteoarthritis, as we can see the degree of joint space narrowing to best advantage with when the patient is weight bearing. And then some other indications, if your patient comes in with an acute onset of trauma, obviously the first thing we're hoping to rule out is a fracture, and that may be an indication for a cross-table lateral X-ray or an oblique X-ray. With the cross-table lateral, we can look for lipohemarthrosis, and with the oblique radiographs, we can see really subtle plateau fractures. It's a best advantage, which can often be occult. Particularly as we go through ski season, we see a ton of those, and they're often really hard to see if we don't get the right imaging. And then a sunrise view, which looks at the patellofemoral joint. We can look for osteoarthritis there and potential manifestations of patellar dislocation or subluxation. So just looking at the views here, the first on the left is an AP weight bearing, pretty standard view. Top middle is a sunrise view where we see that patellofemoral joint come into full focus there. The oblique view at the top right, again, best used for looking for plateau fractures. The lateral image there, which we can see the patellofemoral joint space pretty well, and as well as looking for effusions in intra-articular bodies. And then the tunnel view, which is an angle view that looks right through the intercondylar notch there. That's good for looking for osteoarthritis and intra-articular bodies as well. So just going through some quick pathology here. As we look on the far left, you can see severe lateral compartment joint space narrowing there on a weight-bearing view. You see bone-on-bone contact and subchondral sclerosis with osteophytes. So that'd be a severe case of osteoarthritis, and there's all grades from normal to severe there. In the middle, the cross-table lateral is best used for looking for lipohemarthrosis, which particularly for really subtle tibial plateau fractures, which can be occult, might be the only sign of a fracture that we see. And so that may warrant further imaging with a CT or MRI. And then on the right, looking at a sunrise view, you can see the patella pretty significantly laterally subluxed with a medial patellar facet avulsion fracture there. And for some reason, I feel like it's being more common, or maybe it's just more common recently, but we see transient lateral patellar dislocation injuries, almost every day in our practice now, particularly in younger patients, it seems like. So MR imaging and how to order MR in particular. Most of at Health Images, the vast majority of our MR machines are 1.5 Tesla magnets, and they're completely diagnostic. We do great imaging on those. They're GE machines. We got those up, just optimized as best we can. So you don't need to, particularly in knee imaging, you don't need to order a 3 Tesla magnet. We do have a couple 3 Tesla magnets in our system, one at Health Images Northfield and one at Health Images South Denver. If your patient happens to go to one of those locations, just based on location and availability, they may get a 3 Tesla magnet, but it doesn't really offer a whole lot of advantage in terms of the magnet strength with what we image anywhere else at our other centers with the 1.5 Tesla. So only in very special indications, typically for things like rectal cancer staging, neurograms, prostate MR. Those are things that kind of need to be on a 3 Tesla magnet. A few MSK indications, but for a general knee, a 1.5 Tesla magnet is perfectly acceptable. And when you're ordering almost all indications for knee pain, you should just order a routine non-contrast MRI. Some special exceptions would be if there's strong clinical suspicion for infection, underlying inflammatory arthritis, and evaluation of mass or malignancy. That may be an indication to order an MRI with and without gadolinium. And if you have questions, you can feel free to contact one of us, myself or any of the technologists at one of our Health Images centers, and they'll be happy to kind of walk you through the ordering process if you have questions. Strength of MRI in general it's the best we have for soft tissue definition and evaluation of fluid and edema. There's no radiation exposure. The drawbacks of MRI are it's relatively long, it's expensive. If you have implanted metal, that may be a contraindication, or it may cause significant artifact, even if it's not contraindicated. And then patients with claustrophobia or generalized anxiety typically don't do well in an MR machine. So just running through some pathology here on the top left, we see a layering fat fluid level. That's exactly what we saw on the x-ray from a couple of slides ago. So that's lipohemarthrosis, and you can see a tubular plateau fracture there. In the middle there, we see a large Baker cyst, which is often a pretty common indication for knee pain and swelling. And within that Baker cyst, there's a couple of intra-articular bodies. On the far right, a larger image, we see large hypointense intra-articular masses, and that's a more rare indication, but relatively frequently seen of PVNS, or pigmented villonodular synovitis. And then at the bottom middle image, we see pretty substantial synovial enhancements and bone marrow edema. If I saw this, I'd be concerned about, on a post-contrast MR, I'd be concerned about infection or some sort of inflammatory arthritis there. And then more rare at the bottom left, we see a case of pigmented lipoma arborescens, which is a synovial proliferation that often happens in long-standing inflammatory cases. So CT of the knee, we use it very commonly out of the ER, particularly during ski season up at Summit County. There's some more limited applications, but it's also a workhorse of what we do every day. The most common indications for CT of the knee would be looking at fractures. Another one is looking at bone lesions. We see bone lesions in the internal matrix and the cortex of the bone and the trabecular bone to best advantage with the CT. And so if there's a confusion lesion on MRI or on X-ray, we'll often recommend a CT. And usually those can be done without contrast. We use CT for preoperative planning prior to arthroplasty, looking at arthroplasty hardware after implantation, and in cases sometimes when MRI is contraindicated. The strengths of CT are excellent trabecular bone assessment, very high spatial resolution. It's quick, it's relatively easy for the patient. The weaknesses are there's limited soft tissue assessment. There's a radiation exposure, which is moderately high, and it's relatively expensive. So just coming through here, we can evaluate OA pretty well on a CT. On the far left image, we see some pretty pronounced joint space narrowing with sclerosis and osteophytes. I'd call that moderate to severe osteoarthritis there. In the middle, we have an impacted tibial plateau fracture. One of the most common injuries we see coming off the ski slopes. And then on the far right, we have a bubbly cystic bone lesion that could be confusing on an MR or an X-ray, but on CT you can tell that it has non-aggressive features, and that's most consistent with a non-ossifying fibroma. An ultrasound, pretty rare indications for looking at the knee, except for in the case of looking for DVT as a cause of knee or calf pain, and then looking at Baker cysts. It's also very good for evaluating palpable masses that you can feel or see, confirming that there's fluid within or around the joint, including joint effusions, and then also utilization for direct intervention for aspiration or biopsy of a joint lesion. It's got high spatial resolution. There's real-time feedback, dynamic image. You can do dynamic imaging with it. It's cheap. There's no radiation. Some of the weaknesses of ultrasound, there's low contrast resolution. It's highly operator dependent. And so, it depends on how good your technologist is. And you can't image through bone or air. So bone lesions, and if there's gas around the joint, that can be an impedance. Just a couple of quick cases here on the far left. That's a classic case of a pretty simple appearing Baker cyst. In the middle, we might have a palpable rubbery mass in the soft tissues, and that would be most compatible with a lipoma there. And we could confirm that that's benign etiology on the ultrasound. And on the right, we see a large fluid pocket. It looks like it's a joint effusion, and we could utilize the ultrasound then to guide a needle into that joint and take out fluid if it was indicated to do so. So I'll wrap up my presentation here, and appreciate y'all inviting me here, and appreciate your time and attention.
All right, perfect. Thank you, Dr. Kershen. That was wonderful once again. We're going to now move on to the bulk of the presentation. Dr. Beck is today going to speak to us. She joined our practice at the end of 2024. She brought a wealth of knowledge in orthopedic sports medicine and expansion of our practice being the pediatric orthopedics. Her fellowship is in pediatric orthopedics surgery, and she brings this expertise to CSO to diversify what we can offer. She's also wonderful and is trained in adult sports medicine. So, one of the common things she'll say is she can treat babies to grandmas. So we're excited to have her here. We're excited that she's been able to return to her roots here in Colorado, as she did live in Colorado for a very long time before leaving and going to California, which I don't know why anybody would do that. That's backwards. And she, again, is open to treating people of all ages. Her clinics, fortunately, are been very full very quick because the word has gotten out. She's a wonderful provider, and I'm just so happy to have her here with us. So now here's me, Dr. Beck, presenting on swollen knees, 70 or 7 to 70 for atraumatic cases.
Awesome. Thanks so much. And so great to be here going through just the participants. It's awesome seeing some faces or some names that I know faces to, and some new people as well. So I'm going to go ahead and go through a bunch of fun stuff. I think the big thing about this is by no means is this going to be all encompassing, exhaustive talk about everything that there is in regards to knee effusions. But, my hope is to give you some pearls about how to think about things. People know the old saying that kids are not just little adults. So hopefully I can at least give some kind of differentiation between those two and what to do in those situations. So just kind of briefly, I'm going to go over a little bit of anatomy, really what is an effusion and what creates effusions. Going to go through a couple of physical exam pearls to kind of help make sure and determine where it came from. Going to go through kind of my plan for how I get diagnostic information, if that's going to be aspiration, if that's going to be advanced imaging, what it's going to be. And then I am going to go through some differential diagnoses, which those are things obviously I could talk for hours and hours about. So hopefully people in the chat, if you guys see down there, if you've got specific questions, cases you've seen, interesting things, please, I'd love to have an interactive conversation afterwards and after this talk is kind of over. So first of all, so really what is an effusion? So we all kind of know it's fluid within the joint, but really what makes up the effusion? And there's kind of two main parts to these effusions when you can think of things within the body. There's the synovial fluid, which is the basic fluid, the lubricant that's inside the joint that can change and alter in some of its structures. We'll go through that. But really it's from the synovial lining that expels this fluid that it's really mostly water. Very rare cells, very low protein, very low glucose. It's basically just a hydration of the knee joint, gives some protection to the cartilage, some feeding kind of the cells in the cartilage. But really it's just there as a basic lubrication within the joint. When that changes, when things happen and you start seeing increase in blood cells, increase in white blood cells, increase in proteins is when you start having pathology that changes that actual synovial structure, which can give you an idea of what this, might be the cause by, what do you need to do about it, what in the end may be causing the patient's symptoms. And then the second main really big part of it is it just straight blood? And that's, we'll go through, Dr. Kershen showed a great image. I'll show one as well of what having blood inside the joint looks like. Blood, much lower plasma concentration, much higher cellular count, all those red cells that are in there, all those potentially healing growth factors, but also potentially destructive white blood cells. And really which one of these it is and where you're thinking in your algorithm is going to kind of help tell you what you want to be doing about this and where you may need to go. And when you think about blood, it has to come from a broken blood vessel somewhere. So broken, going to be some sort of trauma, much more common with that. Synovial fluid and changes to that composition with proteins, white blood cells, things like that. That's all coming out and diffusing out of the bloodstream. And so you're not necessarily going to have the broken blood vessels. And that's going to be a bit more of your atraumatic situations that you're going to see synovial fluid changes in synovial fluid versus the hemarthrosis with the straight blood. So this is kind of a similar picture that Dr. Kershen showed, which I think is always really important. And in my mind is what I think about is what's actually inside this swelling. And this is that kind of great image of these fluid levels. And where I think you can really discern that top half, that kind of clear structure, that's just the clear fluid. That's the synovial fluid. And then that bottom half is all of those red blood cells, all of those cells that have now settled. And, the favorite question back in my kind of academic life is, why are these levels there, and what does it happen, and why does it actually form that way? And I think that goes back to how our MRI is done and versus how we actually image them and see them in our clinics, how we're used to seeing them and going through them. And you kind of have to remember in your head when you see these things that, when you're going through an MRI, is the patient is going to be actually laying on their back supine. And so all the big heavy blood cells are going to fall down with gravity. And so that axial image that you have on the left that you're going through, all of the blood cells have now fallen towards the floor, towards that femur. All of the plasma is going to be going up proximally, creating that. And you say, well, okay, it seems very odd. Now that horizontal line is now vertical, and you have to realize that the patient is still in that supine position. We just in our heads have gotten used to how we look at these sagittal images, and the blood cells still are on that, fallen kind of posteriorly aspect versus the plasma in that anterior portion. It's just that we orient these images in that vertical position. And so that's where those cells not standing, upright, they are still going posteriorly. But I think just keeping that in your head when you see these things of what actually could be there this is a really helpful picture for that. Second, when I kind of think of effusions, this is the next picture that comes into my head when I'm seeing a patient with an effusion, is going back to all of the anatomy. As surgeons, that's what we do. We're always going back to the kind of structure of things. And I remind myself that all joints have this synovial membrane that creates this water balloon. And that's what creates a lot of this synovial fluid and can create these effusions. And when you're thinking in your differential of, okay, this patient comes in, really the first thing is, okay, is this water balloon expanded? Is that what's going on? And what's actually inside that synovium? What's inside all of that could be actually causing, if it is a hemarthrosis, if it's blood, or if it is a reactive effusion, what's going on there. And so you have to think of, what's actually intra-articular versus extra-articular. Some of the common things that we see, especially on the sports side, the trauma side, that you commonly hear of are, the ACL tears, the PCL tears, and those are actually intra-articular structures, versus here you can see the LCL, and the same thing with the MCL on the medial side, are actually extra-articular structures. And so when those are injured in isolation, they're actually outside the capsule. And so you can have those in isolation without having an actual big effusion. But really keep this in your mind of what these structures are: the quad tendon that is extracapsular, the patella tendon, all those kinds of things that could be injured depending on the amount of trauma that you have, that are outside the joint that could be contributing versus the things inside the joint. So as we kind of peel back the layers and we think a little bit more inside the joint, so what are things that could be causing that synovial irritation, that could be causing that hemarthrosis? So obviously inside the joint is bone. There's articular cartilage. Things like the ACL, the PCL, the meniscus are kind of these big main things. And I like this picture a lot because I do think it's very helpful in showing that you can see where the break is in the kind of trabeculae in both the distal femur and that proximal tibia. That line right there is kind of representative of where the distal femoral and proximal tibial physes are. And the distal femoral physis is really intra-articular. So you can get injuries to the distal femoral physis and have intra-articular effusions. That's something to kind of think about on your differential, that sometimes may be subtle on your imaging, but you really need to make sure that you pay attention to that. That proximal tibial physis is kind of right at the attachment. And so you really have to have an extension of any sort of proximal tibial physeal injury, has to go up into the articular surface to really create any sort of hemarthrosis. And that's just a little bit of difference in the peds world that you want to make sure that you're thinking of. As we think of some of the other things, and I do want to make sure that we know what actually is an intra-articular effusion versus just having a swollen knee, is there's lots of different bursitis that can happen around the knee. And these are kind of the main ones that you have. That prepatellar bursa is going to be your most common one. I think that people have seen that go around, that you may, see that baseball, golf ball in the front part of the knee. Suprapatellar and infrapatellar are a little bit less common. And then I think Pezan serine is another very common form of bursitis that people can say, oh, my knee is swollen, I've got effusion. Depending on the patient's body habitus, that can be easy to kind of discern, sometimes a little bit more difficult. But as you're going through and hearing the patient saying, oh, I've got a swollen knee, or my swelling comes and goes, and maybe they have that in clinic that day, these are some other places you need to be thinking about of checking of, is it really just a bursitis that's actually extra-articular and it's not truly an intra-articular effusion that you're actually seeing. Here's kind of, the classic thing. And I think it's one of those things that, using kind of all the different physical exam skills. But when I look at this and I tell myself, okay, I'm looking for a swollen knee. What actually is a swollen knee? What is intra-articular versus extra-articular? And I think the biggest thing with an intra-articular effusion is that you're really going to lose contour of the patella. Is the whole entire knee is going to be a big water balloon, is what I always say. But you really lose the contour of the patella because all of that fluid goes up superiorly, inferiorly, medial, lateral. So you have a hard time even saying where is the patella, hard time feeling it. This obviously is a very classic case, very obvious that this one's a big swollen intra-articular effusion in comparison to that contralateral knee. Sometimes it can be a little bit more difficult when it's subtle. So I'll give you in just a minute one of my physical exam maneuvers that I do for that. I think to compare, so that intra-articular one up on that, upper left-hand corner versus these extra-articular prepatellar bursitis there in the center, that golf ball sitting right on the front part of the knee, if that's a direct trauma, repetitive trauma from someone who's maybe kneeling too much, that's far right side with the infrapatellar bursitis. Those are all usually kind of repetitive traumas, just kind of subtle traumas. Could be a direct blow that just sometimes cause that whole bursa to inflate. But you can see in these middle examples, in this right example, you can always tell the contour of the patella. You kind of have an idea where that is, and that the remaining structures, the medial and lateral aspects of the knee, remain relatively intact. And I think that's kind of a way to kind of help tell yourself, is this intra-articular, is this extra-articular, just by kind of visually looking at things. One of the big things also, especially as we talk about different age range, as I kind of mentioned before, is, when you go through and you're trying to decide what this is you're palpating around, is you really need to palpate especially the distal femoral physis. If you've got, anybody really less than 16, obviously it's variations based on age, as well as other issues, kind of different races have different skeletal maturities as well. You really want to make sure that you palpate directly over that area, because you can have fractures to those areas, to those physes, especially that distal femoral physis, that can go unnoticed on just plain x-rays. And it's really your clinical exam of palpating around that area, having your effusion that's there that tells you that you have an injury, especially that distal femoral physis. It can't take a joke very well. And once it gets injured, there's a lot of issues that can happen in regards to growth arrests, angular deformities, different kind of complications. So we really want to make sure that if you do have someone under 16, that you are palpating around the area of that distal femoral physis to make sure if they have pain there or not. Is that something we need to worry about? Those are kind of just being highlighted there. So the kind of two really special tests that I would say any patient with an effusion can have, and obviously there's a very wide range of knee physical exam maneuvers from all the sporties and traumas and things like that. The two I think that you really cannot miss is really just defining how much effusion there is. Not all of your cases are going to be so classic and obvious as that upper left-hand corner. But in your head, you need to get that picture of that water balloon and remember that suprapatellar space is really a large area, and that's where fluid likes to hide. If you've got effusion that's maybe a little bit more subtle, trying to decide if it's there, really this kind of milking blotment maneuver is my go-to test, is that I take all of the fluid from the back of the knee, bring my hands up medially and laterally, and I try and push all that fluid into the suprapatellar pouch. And then I get it stuck up there, and then I can feel around the medial and lateral borders of the patella. And what I do is I then kind of go and I push that fluid distally, and I feel those medial and lateral borders of the patella, and you'll feel that fluid come and press against your fingers. Sometimes when you have, smaller, medium effusions and it kind of gets into little pockets around the knee, it can be really difficult to say. But if you can get that all up into that one space, up into that suprapatellar pouch, collect it all there, and then kind of push it down in a little wave, feel that little outpouching as you feel across the medial and the lateral borders of the patella, that's something that can help you really kind of define, is this really an effusion? Is it intra-articular? You know, what maybe the patient says it's coming and going, to really kind of decide if you have that when it's not so clinically obvious. A straight leg raise, I think, also is the next must have. And this is one that often is very difficult for patients, and no matter their age range, can be very hesitant to do. But it's one of those cannot miss kind of situations, of missed extensor mechanism injuries from quad tendons, subtle patella fractures, patella tendons. We'll go over to the differences between those two in both the peds and the adult side. That's something that you really should make sure that all of your patients can do. They're going to be very fearful about bending, potentially doing any preoperative maneuvers, you know, MCL testing, McMurray's, things like that. But they should be able to do that straight leg raise. And it really doesn't have to be impressive. It doesn't have to look as great as this image with being nice and straight and locked out. But as long as they can get it up off the bed, that is one thing that really you should make sure that all of your patients can do and kind of document. You know, beyond all of this, I think a lot of when you're going through your algorithm is all going to be about your history. And this is really one of those, especially if you've got a younger, fearful child, or if you've got an adult that is coming in, had any sort of trauma, or just is in chronic, you know, had pain, chronic pain, recurrent effusions, whatever it may be. This is really the biggest time. We go back to our days of all of our, you know, history taking, all those classes we took as part of school, asking all of the questions, because the majority of the time, by the end of the history, I already have my differential in my head and have my plan, what's going on. And really the physical exam is just kind of backing that up. And I think it can be, you know, sometimes very straightforward of, my ski got twisted, I was on the last run of the day. As an orthopedic surgeon, don't ever say last run of the day. Just don't do it. Sometimes the history is very clear and obvious, and sometimes it's not. And sometimes you really do have to dig into, what are some of the inciting events? Are there different things? Time of day? Was there some sort of other history going on? What is their past medical history? Was there certain travel that needs to be documented? Is there family history of things? All of those things really is where you're going to spend your time with these patients, is getting their history. And that's really what is going to help, you know, you decide where you need to go with this. And really the one pearl that I will kind of give, for especially the ped side of things, adults are great. Usually adults are pretty good historians, not always, but usually pretty good historians. The hard thing with kids is that kids fall down all day, every day. So no matter what, a kid is going to come in with some sort of swollen knee, swollen joint, whatever may be, painful or not. There's always going to be a history that mom, dad, grandma, whoever comes with them, even the child themselves, may say, oh, I took a trip down some stairs 3 weeks ago, and I had done it several times before, but I kind of twisted my knee then, and maybe that's what started it. And I think especially for the pediatric population, you have to be very careful, because this can very much be a distractor. And you really have to kind of parse down of really what happened. Was there something that happened in that moment? Was there some sort of acute injury? Or is it just the family that's really searching around, trying to figure out, hey, my kid falls all the time. I don't know why their knee's randomly swollen, but my kid falls all the time. So it must be one of those toys they tripped over, or that soccer game that they played in that, they fell down and then got back up. So really just be careful of that. Keep your guard up on that one. So to kind of get into a couple of things, I think, thank you for being part of all of the socials, because this made my life a lot easier, having this kind of parsed into this kind of diagram. And we're going to go into a bunch of these different ones for once you're kind of getting in your history, what to kind of think about, where to kind of go with things. I've got a couple little tweaks to this, but I do think that just putting it into these couple different buckets is very helpful for kind of what to think about things. So, obviously as orthopedic surgeons, trauma is going to be the biggest thing that we think about. And that's probably the biggest thing we do deal with on a day in, day out basis. And I kind of put this kind of red circle around there that, yes, we have to have our guard up and understand we can't miss things. The fractures, especially those intra-articular fractures, bigger injuries, ligamentous injuries, we really want to make sure that we kind of go through our, physical exam as much as we can in our diagnostic workup to make sure that these things have been ruled in or ruled out. And that's going to be, from an orthopedic standpoint, probably the biggest thing that we see from sports fractures, trauma kind of situation. And those are really kind of the must not miss, be on the top kind of front part of your differentials. all of these, and I guess I should, state up front that as orthopedic surgeons and anybody who takes care of anything from a musculoskeletal system, um, each one of these patients is going to be getting a standard set of x-rays. And I think whether they are weight bearing or non-weight bearing is really going to be on their ability to weight bear. And I think the biggest thing that we usually ask patients is can they weight bear? Do they feel comfortable doing that? Is it something they came walking in with that effusion? Or is this something that they say, oh, no way, no how? And then you can get the supine, non-weight bearing x-rays. But from our standpoint, if patients can be weight bearing, especially our adult populations, it is much more beneficial diagnostically for us to have weight bearing films, understanding that balance of we don't want to torture patients and cause them undue pain if they're not able to do that. And so making sure you have those weight bearing x-rays. To kind of piggyback on what Dr. Kershen said, I think that my standard kind of algorithm very rarely includes obliques. I would say for us, it's really going to be AP lateral. And then depending on a sunrise view, looking at that patellofemoral joint or that notch view. And if I can, my preference is to get those four for any sort of patient that's coming in. Obviously, there's going to be some limitations. If they can't bend their knee that far, they can't weight bear, you have to modify that. But in an ideal world, that would give us enough diagnostic information so that we can make the diagnosis and go through things. So going through your workup, all of your patients really should be getting that. And really the question is can they weight bear for the x-ray, or do you need to do them supine non-weight bearing? If you go through and get those as part of your trauma workup, really the next thought is, okay, they've got this clear history, they've got this big effusion, we're pretty sure this is a trauma. Really from a workup standpoint, once you've got the x-rays, I think that's really going to be the major thing. If you go ahead and, and refer, find something at that point. From our standpoint, there are times that we are going to get advanced imaging. From the pediatric side, it is incredibly rare that we order CT scans in general on anything. There are some times, especially if you're doing complex deformities, complex joints, things like that, that we do get them. But I'd say that in general, from a pediatric standpoint, from orthopedics, it is very rare that we get CT scans. And really, it's going to be going straight to MRI if that's something that you're kind of worried about or thinking about. Adults, it could be either way because they are much more likely to have intra-articular fractures that we need to know that exact displacement. We may have more, complicated fracture lines that we need to go and evaluate. And so whether it's a CT or an MRI really depends on what you're seeing on your x-rays, what your concern for your diagnosis is. And so kind of going through there. The one thing I will say, and maybe it's just the bias of we love to have all the pictures, all the information. On the pediatric side, there are times, especially from a sport injury standpoint or from like an osteochondral fracture, or if you're worried about a meniscus tear, which some of those things will go into, there are times that I will request a 3 Tesla MRI, especially if they're getting into the single digits. If I'm looking at a 5-year-old with knee effusions and I'm worried about a discoid meniscus, or I've got an 11-year-old with patella dislocations and I'm worried about a loose body that I'm going to need to go in and fix. There are times that I will do that 3 Tesla MRI, and it's really for me reserved for those younger patients because I do agree the 1.5s do a great job, and with their techniques that they have now give us most of the information. And it's just really making sure in that younger population, or if we're really looking for something, small that we really need to have accurate measurements of, or, a better idea, that's really the only time I get that 3 Tesla MRI. So after trauma and kind of going through your workup, the next thing to kind of think of, the big red flag, the big thing you can't miss is infections. And I think some of these become, if you've seen one before, it comes in, it's kind of that duck. It walks like a duck, talks like a duck, quacks like a duck. It's one of those things that most people find it's pretty obvious if someone's got a septic arthritis and has a big effusion. And really the biggest thing from the biggest pearl is that they absolutely will not move their knee. It is no way, no how. They may do a straight leg raise, but they will not bend, flex. They will not do any sort of range of motion of their knee. Big, warm, swollen. That's going to be the biggest thing. There are a whole bunch of different, obviously listed bacteria that's on here. But if this is really what you're concerned, yes, you're still going to do kind of primary x-rays. Depending on the environment that you're in, obviously an infection is a situation in which this is going to be a surgical, emergency, essentially, that this should be getting referred immediately to an emergency room, really where the next steps kind of get determined by the age of what the patient is. So when it comes to infection, from an adult standpoint, it's typically going to be labs and aspiration for a diagnosis, because adults much more commonly get the actual septic joints, intra-articular effusions. In the pediatric population, because of the abundant blood flow, particularly around the growth plates, around the physis, as I mentioned, that distal femoral physis is intra-articular. The pediatric population more typically gets a bone osteomyelitis, subperiosteal abscess, something like that, that then expands into a septic arthritis. And so we're not so quick to do aspirations in kids. We're actually more algorithms go towards getting labs and then actually getting MRIs, because we know more typically we're going to be taking them to the operating room, and we need to know what the bone component is of that. And so for people who are working in emergency rooms, those kind of situations, that's really the differentiator, is that the pediatric population more commonly has the infection starting from the bone, then leaking out into the joint, versus the adults more commonly starts in the joint, and much less commonly goes into the bone. So malignancy, something obviously that you don't want to miss. This is the reason why everybody gets x-rays. I'm not going to talk about that too much, because I think that's one of those things. You're going to have constitutional symptoms, some other red flags. This is just the why do I get an x-ray for my knee? It's swollen, is to make sure that these things haven't developed. And so that's obviously always in your differential, but you want to make sure that you get to tell them, hey, there's nothing funny going on. I'm happy to say you have normal x-rays, and that there's not any holes in your bone, any moth-eaten lesions, any of those kinds of things. Especially those teenagers with thigh pain, distal thigh pain gets me really worried. Anterior knee pain sometimes, making sure that they don't have, any of those osteosarcomas, anything like that in their distal femurs. And so I do routinely x-ray all of those patients, really for this reason, to make sure that we don't have any signs of these. This algorithm is pretty straightforward. If you see something that in their bone, that's going to go straight to, orthopedic oncologists or medical oncologists, depending what you're thinking. That doesn't typically come to us routine on just the general orthopedic side, sports medicine. But making sure who you know who your referrals are going to be for this is really the most important thing. These last two, I put them in green because, yes, they're there. They're the, on an acuity standpoint, kind of less severe to have to kind of deal with. I think that especially from, lots of you all are primary care that are here, gout, pseudo gout, those kinds of things are very much in your wheelhouse for diagnosing. That's probably something much more commonly that you've already done and then referred to us if it's a second opinion or joint destructions, erosions, things like that have happened. That's something that I think that primary care has done an excellent job of really managing. And, it's very rare for at least me in my practice to see that. Then there's a whole slew of all the rheumatologic conditions that kind of happen. And really when it comes to those inflammatory side of things, that's going to be, I've got knee effusions coming and going associated with pain. That's going to be when you're going to do the aspirations to actually take a look at the fluid, see what's going on, get your cell counts, take a look at all your crystals, make sure that you know what's going on with there. And I think that's something that I think most of primary care folks feel pretty comfortable with. On this other side, the benign tumors, this is where I would say I have a little maybe difference of opinion in who put this together, because benign bone tumors really shouldn't be causing effusions until they've broken through the bone. And so at that point, the non-ossifying fibromas that Dr. Kershen mentioned that we see 1,000 of in kids, really those are not things that should be causing intra-articular effusions, unless the bone has actually broken because they had a trauma, it's gotten so big, the bone has weakened, or maybe it's not so benign. My last practice, we had a large hemophilia group and took care of a lot of that. They're obviously going to have the, history. That's going to be something that you're going to think of and work up. And really that's going to be any sort of going through some of your advanced imaging to find out that it actually is a hemarthrosis, and then doing your blood workup for taking a look at that. But that's something kind of rare further down the line, but that you want to make sure that you're thinking about as well. So if you do ever get to the aspiration, this was a great thing. Thank you for kind of being able to show all this to the Googles as someone who put all this through. Just because a lot of times as you draw that fluid off, you kind of have your diagnosis of what it looks like. Synovial fluid should pretty much be water, should be clear, should be thin, should be easy. Once you start getting some of those proteins in there, some of that non-inflammatory proteins extra in there, it should still be clear, should still maybe be starting to get a little bit thicker, but should still be pretty clear. And that's going to be really that arthritis, wear and tear, or that reactive synovial fluid that's coming in. Inflammatory is when you start talking about white blood cells that are getting introduced, which makes it that thicker color that you can no longer see through. And then as it starts getting real nasty, all the goopy gunk, septic, no one likes to get the needle pull out there, so that you have that, especially in the middle of the night. That's something that you kind of see. And then obviously the hemorrhagic side, when it's just, mostly blood. Those kind of tell you kind of right away, what you're going to be doing. And this is kind of a good thing to keep in your mind as you're pulling that fluid off. What are you expecting? Did it confirm or, alter your differential diagnosis from what the fluid even looks like if you get to the point of aspiration? So just to kind of go through some of the differential of kind of what some things to think about in through all of these, just to give some top ones that I could go on and on forever, but just to put some words and thoughts in your head, wanted to go through some of those. So from a trauma standpoint, obviously, first thing you're going to think about any sort of broken bone that's happened. Here's some big differences kind of between the pediatric and adult side is pediatric bone is much more flexible, much more soft than the adult bone. Adult bone, hard, rigid. When it breaks, it breaks. It's typically a much more obvious fracture. And really the big thing as you're doing that is trying to decide, looking at your x-rays, if there's any other signs of osteoporosis, osteopenia, other things that you could be working up beyond just the broken bone that's there. Getting your history, finding out what the mechanism is, because we know we have a terrible epidemic of osteoporosis, osteopenia here, and we want to be really fighting that for sure. But the fractures, in the adults are typically pretty clear and obvious. The pediatric side, they can be more subtle. When you think of buckle fractures, of just little bends in the bone, that the bone is more spongy, so it actually compresses down. It's, yes, still a fracture. The actual structure of the bone has been affected, but it's not in two big pieces. It's not unstable. It's not, necessarily as obvious. And that's where the x-rays can be sometimes very difficult, where we get a lot of kind of opinions of, is this not? I'm really not sure. It's near a growth plate. Is that a normal buckle? And always happy to kind of be a curbside person for some of those, because I know it really sometimes takes just the physical exam hands-on for that. Obviously, the physis is a big difference for there, and we really need to make sure that we take a look at those physeal injuries. And I've got just a little way that I remember them. That's down here, the Salter-Harris classification. And it's really those Salter-Harris ones that the injury goes through the growth plate itself. That can be the ones that are really based on your physical exam, because your x-rays are going to be completely normal. We don't typically go on CT, MRI, any of those things. It's really based off a physical exam for those. The 2s, 3, 4s are typically going to be more obvious. The 5s are the ones that really we don't diagnose until later, when a complication has happened, like a growth arrest, angular deformity, something like that. And, we are just coming out of ski season, but we are getting into trampoline season. So this is going to be my one plug, that if you have a kid on a trampoline, or an adult even on a trampoline, but in particular a kid on a trampoline that comes in with a swollen knee, that is a fracture, even if the x-rays are normal. And there's some very unique fractures that happen from trampoline injuries that we don't diagnose until later on, when we start seeing the healing bone, but they can have actually very devastating complications when it comes to growth arrests, knee dislocations, vascular injuries, things like that. So in general, as someone who's a gymnast growing up, feels like a little bit of a hypocrite, but we really got to try and advise, especially those young patients, you got to stay off those trampolines, unless you want to keep me really busy, which happy to do, just, hopefully during normal working hours. Other things, when you talk about traumas, broken bones can happen, but then there's also soft tissue. And here's another kind of difference when you talk about pediatric and adult patients, is that adults, we think about the classic ACL tears, PCL tears, very common. Everybody here in Colorado kind of has heard of or knows of those. The pediatric side is that it's actually the bone, the subchondral bone, and the physis that is the weakest part of their musculoskeletal system. So they are much more likely to get avulsion fractures than they are to get ligament tears. And it used to be an old dogma that kids didn't get ACL tears, which obviously we know is now very wrong. But it was much more common that they get tibial spine fractures. And that's where an actual avulsion off of that tibial spine where the ACL attaches happens. And they can be subtle findings sometimes on x-rays. And this is one time, sometimes we do get MRI, because it can be a little confusing. Is it a tibial spine, an osteochondral fracture? Which is it? Can be a little difficult sometimes to discern, but I'd say if you're seeing any sort of irregularity on the x-ray in that area, definitely refer them on, so we can decide what we need to do about that. The adult side, tendon tears, quad tendon ruptures, patella tendon ruptures. Those I think are also big, common, obvious ones where on your x-rays, you're going to see an alteration. Is the patella too high because it no longer has its distal restraint? Is it too low because it doesn't have its proximal restraint? That's usually something that can be pretty obvious to see. It is incredibly rare that kids get quad tendon or patella tendon ruptures. Again, their weakest part is actually at that subchondral surface or at the physis. And so the pediatric version of those are called patella sleeve fractures or tibial sleeve fractures, or they even just get osteochondral fractures of the patella, as mentioned with like patella dislocations. But they can be much more subtle on your imaging, especially on your just plain x-rays. And I think this is one, especially the tibial sleeve fractures, where you can get some irregularity of that tibial tubercle. Ooh, is it that good old Osgood-Schlatter? Is it a tibial sleeve? Is it a tibial tubercle? That can be really difficult to just discern straight off of x-ray itself, and really kind of goes off a physical exam. But that's something to kind of think about, is that you're not going to have necessarily this obvious gaping hole, where a patella tendon or a quad tendon used to be. But you're going to have subtle findings of this little ossifications, little, punctate areas where actually the cartilage has come off with potentially some periosteum, either around the patella or the tibial tubercle. And that's something we really can't miss, because those can be very devastating injuries if they get missed in kids. One of the other things I kind of alluded to earlier is that a very typical history of something I hear is, oh, my kids were playing roughhousing. It seemed like they did it every day. Now my kid's knee's swollen. I'm not really sure. They won't straighten it, things like that. Everyone's heard of meniscus tears in adults, but there is also something called a discoid meniscus, which is an abnormality of how the meniscus actually forms, in that central area where you should have loss of the cartilage. We think it goes through a whole apoptosis as the knee develops to create that C-shaped cartilage. Well, that central part didn't die away. And now you've got this big marshmallow stuck in the knee, which is most commonly on the lateral side of the knee. And anybody who's ever heard of it, sometimes it's called snapping knee. But it's something that, this is a very classic, oh, my kid did this very subtle thing, jumped off that rock wall they've done 50 times before. A couple days later, had something like this. Now they have a knee effusion, can't move their knee. This is one thing that I definitely think about that's a big differentiator in the pediatric population versus the adults. That's much more common to present in that 8 to 16-year-old age range. So not only is it a meniscus tear, but especially if it's lateral, lateral joint line tenderness with an effusion, sometimes popping, clicking, need to kind of think about this discoid meniscus. And that's really where an MRI is going to come in and kind of tell us that. There are some subtle radiographic features that you can find with it, but that's really going to be seen on your MR. One of the other things, that notch view that we kind of alluded to earlier, is one of my favorite views, especially for effusions in kids who are super sporty, do all the things, is looking for this pathology called osteochondritis dissecans, which is really a repetitive trauma overtraining issue. And it can be very subtle. And sometimes if you just get the AP, the subtle lateral can find it, but it's really this notch view that brings this area, the medial femoral condyle, into view, which is why if patients can wait there and get these views, it's very helpful information for us. These osteochondritis dissecans is really where that bone is actually dying and eventually can become a cartilage problem, versus overtraining in adults, repetitive trauma in adults. The bone's not as much the issue. It's the cartilage that takes that brunt of that over time, wearing down, creates all these different, potholes in the road, that chondromalacia word. That's really the adult version. And either of those can cause effusions in knees. But in the pediatric side, it's much more common to come from the bone, first of all. On the adult side, it's going to be more common coming from the cartilage. So those are just a couple kind of highlights of the traumas. Just to kind of go through these last couple ones, infection is kind of a big thing as well. And as I kind of alluded to, adults, I think people know some of the typical symptoms: big swollen, fevers, red hot, won't move their knee. Some of the difference in the younger populations, just to think about, is that gongococcus is more common, prevalent in the pediatric population. And there's also this thing called transient synovitis, which is more commonly discussed in the hip, but can also occur in the knee for kids. So if you have a kid who's had a cough, cold, viral flu, and a couple days, even to a couple weeks later, has an effusion in their knee for no reason, it can be this transient synovitis, which is basically just an irritation of their synovium, causes an effusion. Can be painful, but the key of it is it's very quickly relieved with anti-inflammatories. They can weight bear on it. They have no other fever, systemic constitutional symptoms. I put here the Coker criteria, which is what we use for the hips. We don't really apply it to other joints, but that is something that you may have heard of how we differentiate that. And as I mentioned before, in kids, the bone involvement in the infection much more likely than just intra-articularly. So this is where advanced imaging is really going to come in if we're worried about an infection in a kid, and we're going to go and get an MRI instead of just going straight to aspiration. I will put in kind of that final plug of that red herring zebra is, don't forget about Lyme disease. It is out there for people who have recurrent effusions, have MRIs that have been worked up. Make sure and get them tested for Lyme, because you'd be surprised how frustrated they can be with getting through everything to find out that they had Lyme disease, and they've got an easy treatment, but just we didn't actually do the workup. So this last kind of thing, you know, with inflammation, I think the big thing I would say kind of about this is overuse syndromes. He put in this kind of bucket. It is pretty rare that overuse syndromes, besides if they have structural damage, is really going to cause knee effusions. It's going to be more the tendonitis, tendinopathies. And so I would just be cautious if you've got an effusion just to brush it off as an overuse. Really do some digging underneath there and make sure that you don't find anything else. And I think we kind of talked about those benign bone tumors. That's really going to be your advanced imaging. There's too many to kind of go through here, but if you see something, please always send me an image. Happy to, you know, talk with also your local radiologist about what to do next. Those are really going to be the big things for that. So a couple key takeaways from this is make sure you get a really good history that's going to tell you really 90 to 95% of what you need. And don't forget, every kid's going to have a trauma. Don't let that kind of sway your opinion on, you know, where you're going with this. Make sure you know how to examine for intra and extra-articular effusions. Make sure you get those x-rays, weight bearing if possible. If not, completely understandable, doing the best you can. That advanced imaging, typically in the pediatric population, is going to be more MRI. The adult could be CT versus MRI, depending on what you're looking for. Aspiration really left for, you know, the adult side, infection, rheumatologic conditions, really not a strong role in the pediatric population. And when it comes to everything, know where your referral sources are. Is that if you are that frontline person, know who your rheumatologists are, know who your local orthopedic surgeons are of all different varieties, so that you can always phone a friend, make sure, you know, you're getting the right test imaging, whatever it may be, to help expedite that patient care. So with that, this is my email, and I will put this in the chat also, so that you guys can feel free to email me questions. Hopefully you will put some questions there in the bottom of the chat. And while you are doing that and thinking about things, I wanted to make sure and introduce our final speaker, who is going to be here, unless Dr. Rumley wanted to do it. I'm more than happy to do it.
No, you do it.
Yeah, perfect. Hopefully everyone, you know, learn some things there, put some chat. If you've got cases, interesting things in there, happy to have some discussion. While you're doing that, I'm going to bring on Mark Zaccone, who is the certified athletic trainer, who is my right-hand man for doing everything MA to, you know, seeing patients. He's doing all of our kind of feedback loop with local athletic trainers, anything like that. He's been an athletic trainer for 15 years, works with the Mammoth, has worked with the Broncos, lots of great connections into the community. And the biggest thing I wanted to make sure and bring him on is to help talk to you about some options for when you have these patients in your clinic. How do you manage these effusions, and what can you do from them then and there in the clinic? So Mark, I will have you take it away.
Okay, perfect. Let me share my screen here. All right, so I will be going over briefly just some of the common, a few of the common areas that we instruct patients on when managing knee effusion. And those areas include the compression, pain management, and exercises. So starting off, compression, definitely a big focus when we're trying to manage the knee effusion. And with that, you know, starting off, the elastic bandage, the ACE wraps, they're in office, readily available. Patients usually come in wearing them. Easily adjusted, easily adjustable, easy to put on. I guess my biggest takeaway with those, they definitely, especially around the knee, can kind of bulk up. So there is that user error. So you got to definitely know your patient and know the patient population when we're using these, but definitely easy to use and always available. Then we have our compressive knee sleeves or braces. That's the thicker neoprene knee sleeve, the knee hinge brace. It's definitely what we give out or dispense in our clinic on a regular basis. Definitely better with the support, mild support for the patient, makes them more comfortable. The hinge definitely feels that little bit of stability to there. This is kind of the description of what it would look like. I will say this is, if you have one of the braces to have in your clinic, this is definitely the one for dispensing. This is one of the main ones we do give out. It's the simple hinge knee brace, the neoprene one, and particularly this wraparound brace. I like it more than just the general slip over one, because no one's the same size. Thighs are thicker, the calves are smaller. The open design makes it easier to adjust to that. So definitely use this on a regular basis. The tubular compression bandages, the tuba grip, commonly the recovery sleeves, that's the material that is the spandex type material. They look like it's the copper tone. I like these a lot, especially for the all day use. It's definitely comfortable for patients to use. They come in different sizes as far as the length. You can do a full leg like the TED hose, the knee sleeve here that we have. I definitely believe in the placebo effect. So if your patient, his favorite retired quarterback endorses one sleeve over another, then go ahead and tell them to get that, because if it gives them any type of comfort, knowing that they endorse it, then go ahead and get it. The pneumatic compression devices, the Game Readies, the Normatecs, those are examples. The Brick, I think those are definitely more common now and more readily available for patients, not necessarily just in physical therapy. Patients can purchase them. They're great to have doing sessions of these. They add the element of cold therapy. The Normatec boots have the full leg and can compartmentize the compression. So they're definitely great doing these if they have accessibility to the compression devices. Moving on to, I'm sorry, these are the kind of what they look like, and some examples. Moving on to the pain management, starting off, same thing. The pneumatic compression devices definitely help with pain management, especially the Game Readies or the ones that actually have the cold water moving through them. So definitely something to use when dealing with pain. Kind of the tried and true, the cryotherapy. This is our ice. It's been around. Everyone has it. 15 to 20 minutes on. Biggest thing is we're putting a barrier between the skin. I've gone away from saying this is a way to help with inflammation and more for the pain management. I don't know if the research is kind of showing on as far as inflammation control, but it's definitely great for the pain management. So like I said, 15, 20 minutes on, take it off, make sure there's a barrier between the skin, especially with the gel packs. And then also we want the skin to return to kind of a normal temperature if they reapply or do another session with it. So with pain management, TENS, the TENS electronic stimulation units, these are definitely great for all day use. They've definitely been shown for pain management. It's just basically distracting the pain gate theory. And let me just pull up what these are. You can get these all over the place. Amazon sells them. Making sure they're the TENS and not the NMES or the neuromuscular electric stimulation units. Those are going to be more for your atrophy. So, but basically, if a patient was searching it, definitely the TENS is going to be the one that comes up. My only suggestion with the TENS unit, if you are giving it to the patients, You can definitely see in this picture, they usually come with these smaller pads. And I definitely noticed or have had experience with those are a little more intense with the stem coming out. So if they can get bigger pads, that is usually you have better compliance with the patients when you use the bigger pads. And I also, it's all kind of trial and error when you're using these, making sure if a patient comes in and saying, oh, it's super sharp in one area, but when I put it on another area, it doesn't work. You really have to kind of play around where you're placing these to kind of get the best effect with them. And then last is our exercises. We definitely want to get our patient moving in a safe, kind of controlled way. So starting off really basic, we have our quad sets, heel slides, and ankle pumps. So we're starting to add a little motion through. This is all non-weight bearing. This is going to be your acute phase knee exercises that you can give to the majority of patients. So quad sets, heel slides, and ankle pumps. And then we kind of move on, depending on to the patient, and just add in straight leg raises. So we're getting a little bit of the posterior chain activation as well as our quad activation. And that's all I have for now. So.
Awesome. Thank you, Mark. I feel very fortunate to have someone who has so much, musculoskeletal experience, management, doing these things, working on the sidelines, that it makes my life a lot easier. So if there's ever questions that any of you have or have some MAs or whomever was working with you in your clinic, or you yourself just have some more questions about how to kind of counsel, coach these patients, I'll have Mark put his email as well in the chat box, so that way you guys can make sure that those are answered as well. I did, with our kind of last few minutes, want to make sure that if there's questions out there, case odd things that you've seen, anything that you want to discuss, you've got free reign for what those are. So get those into the chat box. I know kind of I put a message in there for doing that. So make sure and get those in. And what I'm going to do, so the first one, so first thing we want to kind of talk about, and this is an interesting and I think controversial thing, is if you've got a traumatic situation, do you aspirate when you're confident it's a hemarthrosis, you've had a patella dislocation, and that's probably the most common time. You've had a patella dislocation, it's been reduced. They come in maybe to your clinic a day or two later, big swollen knee, pretty painful, hard to move. When do you aspirate that? And I think that there's different orthopedic surgeons and different, sports medicine, I think, providers who have kind of different opinions on that. And I think us on the orthopedic surgery side are a little skewed and biased about any potential complication where we could introduce bacteria into a knee. So I will be honest that in my practice, I do not routinely aspirate hemarthrosis in a trauma situation for a pain relieving standpoint. Patients have to be pretty uncomfortable for me to really want to make that risk, because in my head, as sterile and clean as I want to be, I am putting foreign material into that buffet of deliciousness that bacteria would love to have. And the last thing you'd want is to kind of complicate anything. I understand there are definitely people who, under circumstances, do that. Patients who are really uncomfortable, who are having a difficult time. Maybe they have a difficult time taking different pain medicines, pain management. You've concerns about, issues with those, maybe that it is an option. And so while I say that I don't routinely do it, there are plenty of people who do. I think if you're going to consider aspirating a hemarthrosis, you really have to consider the timing of it. One of the things that I'd say is if it's too soon and the injury just happened and your hemarthrosis is still growing and you take it off, you're just actually going to it's going to reaccumulate because you actually haven't had a chance for that pressure in that water balloon to actually tamponade the bleeding that's happened. So, something just happened 6 hours ago, aspirating something is probably not a huge help to the patient because it's probably just going to continue to grow. There's this sweet spot in the middle where, okay, wasn't too early. Now they've had some where that tamponade effect has happened, that maybe they are at their maximum swelling, that you could do that. And that's going to be kind of that day or two later, potentially. Once you start getting even into 2 days later, that hemarthrosis starts settling. It becomes too big and difficult and thick to kind of get out. And so I don't, after that, really get too aggressive about doing that unless you really kind of feel confident in your aspiration skills and can get even more of some of the just the synovial fluid off the top and not necessarily the cellular layer on the bottom, which just can be kind of very difficult for patients. So I'd say if you are someone who's considering that, really just considering the timing, if you're going to put your patient through that, you want to make sure it's going to be an effective use of that aspiration.
Hey, Jen, you mind if real quick,
Yeah.
I also throw in there, if you do feel confident enough to aspirate it, if you have a hemarthrosis and you have fat in it, it needs to go to an orthopedic surgeon immediately because it's a fracture. And it was a plateau fracture that was missed. And I've actually seen that in the last 3 months. So, and they didn't know any better, but I would say we had a surgeon in Georgia that would aspirate all these knees. And we also had the highest infection rate in that area. So Dr. Beck is more than happy to talk these patients out of a aspiration for anybody that wants.
Yeah. And I think it is hard. I think some people are just uncomfortable, whatever reason, maybe difficult pain management, things like that. I understand how difficult that conversation is. But what I'd say is I'm quick and available getting patients in. If you've got those difficult patients, happy to send them my way, make them my problem so that way I can kind of go from there and I'll take that whole conversation off your shoulders so that you don't have to have that. And I think Dr. Rumley's point is very good. If you pull that blood off and it's just blood, that could be torn ACL, meniscus, but the fat droplets are going to be clear, oily. It's going to be that olive oil in the pan. You're going to see those fat droplets. If you see that is absolutely correct. That should be sent immediately to an orthopedic surgeon, probably getting advanced imaging of some sort to find out where that interarticular fracture is. So great point. Okay.
So Dr.
And then
Beck,
I think
off the chat, something great that I don't have the answer for, and I know you do. How do you treat Baker's cysts?
great. Okay. Baker's cysts, one of those ones that we don't see them in the front of the knee as often. So I didn't kind of go there, but yes, we see those quite often. So the thing with Baker's cysts is that it is very rare. Well, I should say there's Baker's cysts in pediatric patients and there's Baker's cysts in adult patients. So I think we need to be clear. This is definitely a differentiator of age range. Plenty of times Baker's cysts can happen in kids age even 4 to 10, I'd say would be kind of the oldest we'd start seeing it in. Atraumatically happens. All of a sudden they have this swelling in the back of the knee. Any swelling around knees in kids makes people's, gray hairs all stand up for worried about tumors, infections. In that pediatric population, it's something that we just monitor. We don't aspirate. We don't do any sort of anything, and they just happen. That is very different than the adult population where Baker's cysts typically happen for a reason. So either there is cartilage damage, starting of arthritis, meniscus tear, some reason that there's been fluid that's accumulated inside the knee over time, and it's outpouched out that medial channel behind that medial gastroc. And so I think the days where some people aspirated those, similar to a lot of those, they tend to just come right on back. So I'm not aggressive about aspirating them by any means, but I am aggressive about finding out why they're there in the first place. Because if there is a meniscus tear, chondral damage, something like that, that we can be treating to get that Baker's cyst to go away, that's what your primary focus should be. I will say one little caveat that there are some people who have these recurrent ones, especially in the setting of mild arthritis, that there are some people who are doing some arthroscopic techniques to try and close off the channel to actually stop them from happening. That's newer, pretty rare, and I'd say that would be pretty aggressive for people to need to do that. They would need to have really wildly symptomatic from not being able to flex their knee before I would really even consider doing that. And so it's really, you have the Baker's cyst, it itself is not the problem. Let's find out what the real problem is and diagnose that and treat that. Perfect. Okay, couples. Yeah. So second great question that was in here is that what about, so Baker's cyst, So practice for obtaining x-rays consistent with Osgood-Schlatters. So Osgood-Schlatters, yes, for the most part, is a clinical diagnosis that it is tender on that spot right there. This is one of those, we get x-rays to make sure it's not funny things, because the funny things that have happened that I've seen in practice, seen in fellowship, is that you can get chronic infections actually back there. And I've actually seen Brody's abscesses that have just started posterior to that tibial tubercle, that if you had just put your finger on there, a little red, little warm, little sore, great, walks like a duck, quacks like a duck, it must be Osgood-Schlatters. But we always get x-rays, and it's really the lateral that we're going to pay more attention to really rule out anything else, such as bone lesions, bone tumors, Ewing sarcomas, giant cell things, infections, Brody's abscesses that are back there. So the one, if you're going to kind of go for broke, it's really going to be your lateral. That's going to be your most important one. And I think your physical exam is going to tell you, when you actually look at that tibial tubercle, sometimes it's going to be kind of fragmented, and it's going to be very questionable. You're going to get a radiology read of, is that a fracture? Is it not? And it's really going to be, this patient walked in, they were at track practice yesterday, their knee hurts, or, oh, they were about to jump into a pool, catch a rebound for, playing basketball, felt a pop. There's going to be very clear different history about a fracture versus the ossification variant that happens when tibial tubercles go through their ossification cycle. Let's see. I saw one, chronic joint mice. Do they need to be removed when tucked in posteriorly? So when you have kind of chronic loose bodies, it really depends on where it came from and what the real symptom is. There are plenty of times that people have cartilage that comes off for whatever reason, if it's a trauma, patella dislocation, arthritis, that can go and kind of circulate around. What we get really concerned about is when they actually create mechanical symptoms, or they're actually pinballing around the knee, potentially causing other damage along the way throughout the cartilage. Sometimes they will get tucked and then adherent, particularly to the synovium in the back of the knee, because there's not as much space back there. So when they get caught and stuck back there, they tend to stay back there. And so that's really going to be dependent on what your patient's symptoms are and what the MRI looks like. If it looks like an obvious loose body, they're having mechanical symptoms, something getting stuck, yeah, those are things that we typically want to go and take out. But if you just happen to see it on MRI, looks like it's stuck, especially to that posterior synovium, I don't get aggressive about taking them out, because really it's a matter of treating the patient's symptoms. And if they're not having symptoms from it, I don't get aggressive about taking it out. But I do want to find out where it came from. Have you seen loud creaking in a knee months, years post-op, specifically meniscus repair, that would be attributed to changes in synovial comfort? Okay. So creaking knees after surgery, specifically after meniscus repair, does it change the synovial fluid composition, or is there any reduction or change in it? Creaking in joints is very interesting, because I don't think we have a great answer for it. And I think the answer, as much as I wish as I had one for this, is I don't think there's a change in the synovial fluid. Is that creaking sometimes happens either depending on what the actual repair was done, what the location was it, is there soft tissue that's kind of happened? Is there a synovial fold that's created that's kind of creating some of that creaking? So I haven't seen that I haven't seen any studies that have directly assessed the synovial fluid composition to say if it's changed, because the fluid itself shouldn't be really making the noise. It's actually the friction of the two structures against each other. And after meniscus repair, especially some of those discoid meniscus in those younger patients, it is very common that people feel kind of creaky feelings in them. And really my answer to that always is, do you notice it, but you can go on your way? You just can't sneak up on somebody, at a Halloween party. Or is it something that's painful and problematic for you? And really, I don't start getting worried or doing anything MRI is aggressive unless they're truly having pain or symptoms from it. If it's just that, oh, I bend and straighten my knee, I have a little creak. Okay, joints do that, because diagnostically and therapeutically, it's very difficult to sometimes get to the bottom of that. See, that's a great question, though. So I think if I've gone through all of these, If there's any other questions, speak now, forever hold your peace, or email me or reach out to me anytime. So perfect. Those were some great questions that's there. And I also am kind of seeing the time. So I would love to thank everybody, first of all, for coming. It has been such an honor to be part of the CSO program, being here 6 months, getting up and running, providing all of this care for all ages, sports medicine, pediatric patients. It has been just a true joy for me joining this practice. And hey, a bottle of wine is not a shabby thing to get at work. Not many places can say that, especially Greek wine. So what I'm going to do is I'm going to have Jenna Minichi, our marketing director, that you are probably super familiar with on all of the emails, all the contact information. I'm going to have her kind of give a wrap up with some of the administrative stuff, make sure that everybody's got their information, get their CME, get their recordings. So I'm going to have her get all of that. And again, my information, Mark information's in the chat. And thank you everyone so much for coming tonight.
Hi, everybody. Jenna Minetti here, Marketing Director. Thank you so much, Dr. Beck, Dr. Kershen, and Mark, and Dr. Rumley. We appreciate you guys and all of your expertise. I do not see any additional questions in the chat. So at this point, we can go ahead and wrap it up. I do want to thank everyone so much. We had really great attendance for this event. So thank you guys for your attendance, your support, your referrals, and your partnership. We appreciate each and every one of you. You all have my contact info. Please reach out to me with any questions you have, stat referrals. If you want cell phone numbers of any of our providers, I'm happy to give those out. Any information that you need or want from us, or anything I can do to help expedite referrals or even troubleshoot referrals, I'm always here to help. Lastly, thank you also to Dr. Kevin Downs. He selected a really exciting wine this time. I feel like I've been to Greece and everything. Wanted to let everyone know too, final reminders for your CME information. I will send an email out tomorrow with all the information that you need to obtain the CME. You will have to log in and create an account in order to obtain it, but it takes 5 minutes. I promise it's not that difficult. And you will have 30 days to claim this CME. So make sure when you get the email, go ahead and claim it immediately before you forget, because that 30-day window will go away very quickly with all the patients that we are always seeing. So if for some reason you do not get that email, shoot me an email. I'll make sure that you get it. And then lastly, again, thank you everyone. I hope you enjoyed the wine, and just a little salute to have you and go enjoy your evening with your families. So cheers, and thank you guys, and reach out to us with anything that you need. And one last huge shout out and thank you to Health Images, our co-sponsor for the event. Thank you everyone. Have a wonderful evening.